All right, everyone, welcome. We're diving straight into a high-yield board review on knee osteoarthritis. Everything we're covering today is pulled directly from the clinical practice guidelines. No fluff, just the essential, testable facts you need to know. Let's get started. Okay, here's our game plan. We've got 6 key areas we're going to hit. We'll start with the basics of what knee OA actually is, then we'll get deep into diagnosis, both clinical and radiologic, and finally, we'll wrap up with the really practical stuff: rehab, exercise, and patient education. It's all designed to build a solid framework for you.
Okay, let's kick things off with Module 1, the foundation. You can't diagnose or treat what you can't define. So let's nail down exactly what we mean by knee osteoarthritis.
So here's the textbook definition. Osteoarthritis, or OA, is a chronic degenerative joint disease. We're talking about the progressive loss of hyaline cartilage, damage to the bone underneath it, synovial tissue damage, and the formation of those classic osteophytes. At its core, OA is a failure of homeostasis. That's the money phrase. The joint's whole ecosystem, the cartilage, the chondrocytes, the subchondral bone, it just can't keep up with the damage from all the mechanical and biological stress. That balance gets thrown off, and that's what kicks off this whole degenerative cascade.
All right, with that definition in our back pocket, let's move on to Module 2. This is all about clinical identification. We're taking that foundational knowledge and applying it. How do we actually spot this in a patient? And more importantly for your boards, how do we standardize that diagnosis using objective criteria?
Okay, these are the cardinal symptoms. You absolutely have to know these cold. We're looking for joint pain that's been going on for at least a month, some intermittent swelling, and limited mobility, especially with flexion. And a couple of big ones here. That morning stiffness is a key differentiator. Notice it's less than 30 minutes. That's a classic board question to separate it from something like rheumatoid arthritis. You also get that bony crepitation, that grinding or cracking sound, and in more advanced cases, you'll actually see bony deformities.
So the patient comes in with this cluster of symptoms. How do we take that clinical picture and turn it into a standardized, official diagnosis? That is the million-dollar question. And the answer, especially for your exams, lies with the American College of Rheumatology criteria. The ACR criteria are absolutely essential.
Okay, let's look at the first set of ACR criteria. This is the clinical and lab-based pathway. The rule is the patient must have knee pain plus at least 5 of these 9 findings. You'll see it's a mix of things you find on exam, like age over 50 and crepitus, along with lab results that are basically ruling other things out. So, for the boards, what are the numbers you need to know for this combo? Memorize this: 92% sensitivity and 75% specificity. High sensitivity, decent specificity.
All right, pathway number 2 is clinical and radiology. This one's a bit simpler. You need knee pain plus just 1 of 3 things. The third one is the biggie because it brings in imaging. So how does that change the numbers? Well, the sensitivity is still excellent at 91%, but look at that specificity. It jumps up to 86%. Why? Because you've added that hard objective evidence from the X-ray. It's less likely to be a false positive.
Okay, and our third and final pathway is the clinical-only criteria. This is what you'd use when you don't have labs or X-rays handy. Here, you need knee pain plus at least 3 of these 6 clinical findings. But this is a classic board exam trap. What's the trade-off here? Well, you get a massive 95% sensitivity. It's fantastic at not missing the disease. But the specificity plummets to 69%. So you'll catch almost every case of OA, but you're also going to incorrectly flag a lot more healthy people. Okay, we're still in Module 2, but we're going to pivot now and focus exclusively on imaging. This is crucial. X-rays aren't just a checkbox for the ACR criteria. They're how we stage the disease, which is going to guide our entire management plan.
So when you order these X-rays, you can't just write knee X-ray on the script. You need to be specific. The guidelines are very clear on the projections you need. You need a posterior anterior, or PA view, that's bilateral and weight-bearing, so the patient is standing on it. That's the only way to properly assess joint space narrowing. Then you need a lateral view and an axial or sunrise view to really get a good look at that patellofemoral joint.
And once you have those images, this is how you grade them. The Kellgren-Lawrence scale is the classic system, and you've got to know it. Grade 0 is normal. Grade 2 is where you see your first definite osteophytes. Grade 4 is end stage. But here is the single most important clinical pearl about knee X-rays. Treat the patient, not the X-ray. The radiographic findings frequently do not correlate with the patient's symptoms. I've seen grade 4 knees in people who are hiking every weekend and grade 1 knees in people who can barely walk. Never forget that disconnect. All right, that brings us to our biggest section of the day, Module 3, Practical Intervention. We've defined it, we've diagnosed it. Now, what are we going to do about it? We're going to walk through the evidence-based, non-pharmacological management strategies, straight from the guidelines.
Now, a really important point before we dive in. This is a review based on the rehabilitation guidelines. We all know that medications, NSAIDs, injections, they're a huge part of the overall picture. But for the purpose of this review, we are sticking strictly to the non-pharmacological interventions. That's what our source material is focused on.
First up, let's talk thermal modalities. Heat versus cold. It all comes down to timing. Think of it this way. Cryotherapy, or cold, is for acute situations. A flare-up, post-activity soreness. You use cold in those first 48 hours to clamp down on inflammation and numb the pain. And thermotherapy, or heat, that's for the chronic day-to-day stuff. You use it before activity to loosen things up, improve blood flow, and get the muscles ready to go.
Okay, moving on to electrotherapy. TENS is the one with the most specific guideline recommendation, and this is a really high-yield point. The ACR specifically calls out TENS for patients with moderate to severe pain who are not surgical candidates. That's the key patient population. And it's not a quick fix. The evidence shows it's most effective when it's used for more than 4 weeks.
All right, still in Module 3, and now we get to the absolute cornerstone of knee OA management. Without a doubt, therapeutic exercise. If there's one thing that has the most evidence and provides the most benefit, this is it. It is the single most important non-pharmacological intervention we have. So when you're thinking about an exercise program for these patients, it's not just about lifting weights. A truly comprehensive program has to hit all 5 of these core goals. You have to improve joint range of motion, you have to build strength and endurance, but don't forget coordination and proprioception, the joint's sense of where it is in space. And finally, you have to improve overall aerobic capacity. You miss one of these and the program is incomplete. Okay, let's drill down into strengthening. There are 3 main types. First, you've got isometric, where the muscle contracts but the joint doesn't move. Then there's isotonic, where the joint moves against a constant resistance. And finally, isokinetic, which usually requires a machine to keep the speed of movement constant. And here's a great clinical pearl. While all are useful, the evidence suggests that isokinetic exercise is actually more effective than isometric exercise for both improving strength and reducing pain.
Okay, if you're zoning out, come back for this slide. This is the cram for the exam summary. Point 1, strengthening the quadriceps is king for pain relief. Point 2, don't get hung up on the type of exercise. Aerobic, aquatic, resistance, they all work. The best exercise is the one the patient will actually do. Point 3, frequency is key, at least 3 times a week. And the final, most important point, exercise is a first-line treatment. It's where you start with every single patient.
Okay, to wrap up our big intervention module, let's talk about the things that support the exercise program. We're talking about orthotics, walking aids, and the thing that ties it all together, patient education. These are the tools that help make the exercise plan successful. Pay close attention here because this is loaded with testable facts. Insoles are tricky. For lateral compartment OA, you use a medial wedge to shift the pressure. For the much more common medial compartment OA, you use a subtalar or lateral wedge. They will absolutely test you on that. And walking aids, like a cane, you hold it in the hand opposite the painful knee. And just by doing that, you can reduce the load on that joint by up to 60%. That is a huge effect. What's this number? 25 kilograms per meter squared. That's the target BMI. The guidelines could not be more clear on this. Weight management is a cornerstone of therapy. Getting a patient's BMI under 25 is one of the single best things you can do to reduce their pain and slow down the actual progression of the joint damage. And the physics are just undeniable. For every 1 pound of body weight a person loses, it takes about 4 pounds of pressure off the knee with every step.
So that brings us to our final thought. Let's pose a question. We know exercise is effective. We know these other tools can help. So if you design the perfect, evidence-based program, what is the one single factor that will determine whether it actually works in the long run? The answer has nothing to do with isokinetics or TENS units. It's adherence. Did the patient understand the why? Do they have the tools for self-management? Do they actually do the program? At the end of the day, patient education and long-term adherence are what separate success from failure, and that's really the ultimate takeaway.